Yes. So, mhm. Well, good afternoon, dear students. Hi there, if you are present really here, right, right nearby your computers. I don't see anybody, but in any case, we'll start now. So, we'll discuss today the polyclinic management of acute and chronic pyelonephritis and the chronic renal failure as the usual trivial outcome of any kidney disease. So, uh, we consider so-called urinary tract infection. It occurs in all populations, from nanny to geriatric patient, but it has a particular impact on females of all ages, especially during pregnancy, males at two extremes of life, so young and elderly, kidney transplant patients, and anyone with functional or structural abnormalities of the urinary tract. So, we distinguish two types of the urinary tract infection, like upper urinary tract infection, we define it like pyelonephritis, and lower urinary tract infection like cystitis. We'll start from definitions. So the pyelonephritis means inflammation of the kidney and its pelvis, but from a historical point of view and through common usage, the term has come to designate a disorder of the kidney resulting from bacterial invasion. You see here the list of the bacteriological findings of pyelonephritis, and you can discover some difference between the outpatients and inpatients, or in other words, hospitalized patients. Escherichia coli in outpatients takes the first place, up to 90%. But in patients, Escherichia coli also takes the first place, but with some different spectrum of uh, bacteria and some other constituents. But in any case, we have to take into account the pathogenetic factors, which predispose to pyelonephritis, which are urinary tract obstruction, vesico-ureteral reflux, instrumentation of the urinary tract, pregnancy, and at last, the diabetes mellitus. And we consider two potential routes, like the hematogenous route with the seeding of the kidney during the course of bacteremia, and the ascending route from the urethra to the bladder, then from the bladder to the kidneys via the ureters. Hematogenous infection. Remember that the kidneys receive up to 1/4 of the cardiac output, and any microorganism that reaches the bloodstream can be delivered to the kidneys. And the major causes of hematogenous infection are Staphylococcus aureus, Salmonella species, Pseudomonas aeruginosa, and Candida species. Ascending infection. The reservoir from which urinary tract pathogens emerge is the gastrointestinal tract. And females, because of the proximity of the anus to the urethra, are at increased risk for urinary tract infection. Clinical presentations. Cystitis. Cystitis, clinically it uh, produces dysuria, or in other words, burning or discomfort of urination, the frequency of frequent urination, nocturia, and some suprapubic discomfort. And clinical presentations in acute pyelonephritis and in chronic pyelonephritis exacerbations look in such way with the recurrent rigors and fever, back and loin pain, colicky abdominal pain, nausea and vomiting, dysuria, frequent urination, nocturia, and gram-negative sepsis and septic shock in some very advanced cases. The physiologic derangement that result from the long-standing tubular interstitial injury lead to development of the arterial hypertension, inability to uh, conserve or retain sodium, decreased concentrating ability, and tendency to develop hyperkalemia and acidosis. What are the probable complications? These are the sepsis, perirenal abscesses, acute renal failure, renal papillary necrosis, and at last, chronic renal failure. What about the diagnostic approach, diagnostic evaluation? We must take into account the history and physical examination, to perform chemical tests for the presence of bacteriuria, to evaluate the urinary concentrating ability. It's the measurement of urinary enzymes, measurement of C-reactive protein, measurement of antibody responses to bacteria, and radiologic and urologic evaluations. Laboratory findings. The simplest approach is the usage of urine dipstick to reveal pyuria on microscopic examination whenever we discover it with the dipstick, and to reveal the increased amount of white blood cells in urine. We have to evaluate the bacterial account. In the case of pyelonephritis, it increases 10 in the 5th degrees per milliliter, but we should take the urine from the middle stream. And at last, the blood culture, whenever we suspect the systemic septicemia. The next, we have to evaluate the urinary concentrating ability. With the maximal urinary concentration test, we expect to see the decreased specific gravity. The very valuable and very useful analysis, these are the urinary enzymes like N-acetyl beta-D glucosaminidase, like NAG, and beta-2 microglobulin. The next, urinary tract X-ray with such an abbreviation, acronym: kidney, ureter, bladder, abdominal X-ray, and IVU, intravenous urography. The next, ultrasound investigation, and at last, computer tomography and magnetic resonance imaging. Now you see the result we got with retrograde parallelogram. It shows that the upper pole calyx is stenotic. You see the arrow which shows it, with associated papillary necrosis. The adjacent calyx is fibrotic and distorted as well. The next one, excretory urogram. 10-minute film, it demonstrates enlarged right kidney with minimum function, and these findings are consistent with edema. And the next was the ultrasound of the same kidney. It demonstrates the enlargement of kidney with hypoechoic parenchyma and compressed central collecting complex. This data obtained shows us about the significant right-sided pyelonephritis. The next, acute bacterial pyelonephritis, and this color flow ultrasound demonstrates diminished blood flow through the involved area of the kidney, is the lower pole of the kidney. The next one, computed tomography with the intravenous contrast enhancement. It demonstrates a perfusion defect and enlargement of affected right kidney in acute pyelonephritis. Treatment. Such an approach, these are the basic measures like rest, drinking large amount of water, antibiotics. The duration of such treatment varies from 10 to 14 days until symptom-free. And we have to treat related underlying diseases like diabetes, renal stones, vaginal infection, and so on. Antimicrobial therapy. We have to follow three goals: control or prevention of the development of urosepsis. The next, eradication of the invading organism, prevention if recurrences, and medications. It depends on your doctor's choice, like trimethoprim sulfamethoxazole, the wide spectrum on fluoroquinolones, and the antibiotics like ampicillin, amoxicillin, the group of cephalosporins. Short course therapy also may be used with the single dose therapy and or 3-day course of therapy. And extended course, it means the prolonged from 4 to 6 week course of therapy, and low dose prophylactic regimen. It concerns low dose antibiotics 3 times weekly at bedtime for a half to 1 year. What about the polyclinic follow-up? Patients with chronic pyelonephritis are taken for dispensary registration, examined at least 2 times a year. Clinical examination is performed by nephrologist or urologist and the general physician therapist. In the presence of hypertension, anemia, impaired renal function, the examination is carried out at least once a quarter, once a 3 months, in other words. And then salt and fluid should be restricted. Spicy dishes, meat and fish broth, alcohol should be excluded and avoided. Employment excludes significant physical stress, adverse weather conditions, cold, damp, night shifts. And with the exacerbations of the disease, hospitalization in the hospital nephrological or urological departments is indicated. Now we move to polyclinic management of chronic renal failure. We'll start from definitions as usual. So, the chronic renal failure is a progressive, irreversible loss of renal function over a period of months to years. Remember, please, the kidneys can lose up to 80% of all nephrons with relatively few over changes in functioning of the body. And nephrons are destroyed and replaced with scar tissue. Remaining nephrons become hypertrophied and eventually fail to function. And resulting the chronic renal failure results in alterations in all of body's system. The most common causes of chronic renal failure are glomerulonephritis, interstitial nephritis, diabetic nephropathy, hypertensive nephrosclerosis, and polycystic kidney disease. You can compare the gross morphology of renal scarring. You see how looks the normal kidney on the left panel and the scarred kidney on the right panel. You see the very great difference between these two entities. So we can propose many classifications of the chronic renal failure, but in general it divides into groups before dialysis and when dialysis is indicated. So the general criteria for chronic renal failure is the glomerular filtration rate below 25 milliliters per minute. So we can distinguish 4 stages of decreased renal function. These are, first, silent, when the GFR is up to 50 milliliters per minute. Renal insufficiency if the glomerular filtration rate is in the range between 25 to 50 milliliters per minute. Renal failure we define as glomerular filtration rate is in the range between 5 to 25 milliliters per minute, and at last the end stage renal failure when the GFR is below 5 milliliters per minute. Uremia, or in other words, azotemia, is a term applied to the manifestations of organ dysfunction seen in stages 3 and 4 of chronic renal failure. In other words, uremia means urine in the blood. Azotemia, the accumulation of nitrogenous waste products, chiefly urea, in the blood is the hallmark of renal failure. And in general, it is a clinical syndrome resulting from retention of certain substances which are normally excreted into the urine and thus accumulate, causing toxicity. What are the general symptoms of chronic renal failure? Subjective, like metallic taste in mouth, weakness, irritability, fatigue, nausea, anorexia, pruritus. And objective, ammonia, or some people can say urine, odor to breath. Then oliguria up to complete anuria, tachycardia, arrhythmias, hypertension, rapid weight gain, dry scaly skin, and at last peripheral edema. Now we'll discuss the clinical manifestations. So, retention of nitrogenous wastes, it leads to azotemia with the increased level of BUN, it means blood urea nitrogen, and serum creatinine. And uremia means the presence of signs and symptoms of azotemia. And fluid volume excess. The next, metabolic imbalances, like electrolyte imbalances, with hyperkalemia, hyperphosphatemia, hypocalcemia, hypermagnesemia, and hypernatremia, usually delusional, and acid-base imbalance with the development of metabolic acidosis with the decreased level of pH and decreased level of bicarbonates in the blood. The next, effects of renal failure on the body systems. These are genitourinary with oliguria, urinalysis findings with the presence of casts, red blood cells, white blood cells, and protein. Specific gravity typically is decreased and fixed at the level of 1010, or in other words, 1010. And urine osmolarity is lesser than serum osmolarity. And creatinine clearance is decreased. Neurologic manifestations are fatigue, confusion, lethargy, changes in level of consciousness, and in the very advanced end stage cases with SAGES and coma. The next, cardiovascular effects with arrhythmias, hypertension, hyperlipidemia, and peripheral edema, with the development of the heart failure and uremic pericarditis. This clinical, or better to say, auscultative symptomatics of uremic pericarditis. It has such a definition as funeral bells. Funeral bells. So it means that the patient should be immediately undergo the hemodialysis procedure. The next, respiratory. Cosmal respiration, crackles, and pulmonary edema, uremic pleuritis. Gastrointestinal, anorexia, stomatitis, metallic taste in mouth, and uremic fetor, and sometimes gastrointestinal bleeding. The next, integumentary, with pruritus, dry skin, brittle nails and hair, ecchymosis, pallor or yellowish bronze discoloration of the skin. When terminal uremic frost rare today, sure, if we discover such symptoms, the patient is already lost for some hemodialysis procedure, so we practically never achieve such a very deep degree of the uremia. The next, musculoskeletal, muscle cramps and weakness with food drop. Long-term, renal osteodystrophy resulting in bone pain, deformities, and pathological fractures. The next, hematological signs, with the development of anemia, decreased level of platelets, which lead to prolonged clotting times and decreased leukocytes. Endocrine, with the glucose intolerance, reproductive, decreased libido, and infertility. The complications of the chronic renal failure: SAGES, coma, heart failure, pericardial and pulmonary effusions, gastrointestinal ulcerations and bleeding, renal osteodystrophy, and secondary hyperparathyroidism. What about the conservative management? We have to control the fluid imbalance. We have to control volume excess with fluid restriction. When the 24-hour urine output, we add 500 to 600 milliliters. So, in other words, the fluid intake should be restricted to daily urine output with the addition of a half of liter of fluid. But the best way to control, to evaluate the fluid volume excess, fluid deposition is the daily weights measurement. Ensure input-output, but weight follow-up is more important, more valuable, because sometimes we are not able to uh, make some precise measurement of input and output. And also we have to treat hyponatremia. Diuretics, very useful, very essential treatment. We use the most active, more effective diuretics like furosemide Lasix and osmotic diuretics like mannitol, osmitrol. Both of these diuretics promote diuresis and increases renal blood flow. We have to control electrolyte imbalances. At first, the hyperkalemia. We can control the hyperkalemia with intravenous glucose and accompanied by regular insulin, which forces potassium out of serum and into cells. We have to use intravenous sodium bicarbonate, which creates temporary alkalemia, moving hydrogen out of cells and allowing potassium to shift into cells. Then we can use calcium gluconate, which reduces myocardial irritability, decreasing risk of arrhythmias. And at last, polystyrene sulfonate, caoxalate, and this calcium exchange resin binds with potassium in bowel, promoting elimination in stool. But in any case, you have to remember the best way to control hyperkalemia is hemodialysis. The next, hyperphosphatemia. We have to use phosphate binders, which bind to phosphate in bowel and promote excretion in stool, given with meals. These are renagel or calcium acetate. How to control hypocalcemia? We have to add the supplements of calcium and to give synthetic active vitamin D like calcitrol, rocaltrol. The next, to control acid-base imbalances with intravenous sodium bicarbonate. How have we to treat hypertension? We use AC inhibitors, angiotensin II receptor blockers, ARBs, and calcium channel blockers, CCBs. Anemia. We can control it with red blood cells transfusions, usage of epogen, which stimulates the production of erythrocytes, and ferrous sulfate and folic acid supplements to treat anemia. How to prevent the complications and some symptoms control. We have used anti-seizure drugs, anti-ulcer drugs, antiemetics, antibiotics. Sure, we have to control the doses of antibiotics, taking into account the level of the glomerular filtration rate, and antipruritics to control pruritus, dry skin, and so on. So, the next point, it's the dialysis therapy. We use two types of dialysis therapy. It's the hemodialysis and peritoneal dialysis. What are the indications for chronic dialysis? These are the end-stage renal disease with hyperkalemia, nausea, vomiting, anorexia, mental confusion, increased lethargy, fluid overload despite medical therapies, and at last pericardial friction rub, which indicates an urgent need for dialysis. I told we name it like funeral bells. Hemodialysis is the most common method of dialysis. It may be used for lifelong therapy. It takes usually 3 times a week for 3 to 4 hours for each session. It prevents death but does not cure renal disease. It's the kidney function support. And in general, the dialysis machine removes dirty blood, cleanses it, and then returns it to the body. It's the very, very schematic definition of this rather sophisticated and cumbersome procedure. So we have to provide the vascular access. Then we'll have dialysis machine, dialyzer. A dialyzer is the tube-like apparatus containing a semi-permeable membrane and dialysate solution. This solution contains all the important electrolytes in ideal cellular concentrations. And this solution can be adjusted based on the patient's need. How looks the room for hemodialysis? You see here the dialysis machine having the central device for it. It's the hemodialyzer, hollow fiber hemodialysis. It's the most advanced device, and the process of hemodialysis looks like blood is removed from the arterial end and pumped through the dialysis machine to the dialyzer at the rate from 200 to 400 milliliters per minute. It's a rather rapid flow. And the heparin should be added to blood to prevent clotting with the in the dialysis machine, and the dialyzer receives arterial blood flow along one side of the semi-permeable membrane with the dialysis solution flowing along the other side, usually in the opposite. Not the usually, but practically in all the cases. So it's the so-called counter-current direction. And the physical processes which go on the semi-permeable membrane are the osmosis, diffusion, and ultrafiltration. And the filtered blood that is returned through venous access to the patient. The next, main types of peritoneal dialysis. These are the continuous ambulatory peritoneal dialysis and continuous siting peritoneal dialysis. Both types of the peritoneal dialysis are not so popular because they need the very good cognitive function of the patient and very good cooperation with the medical system, with the doctor. So the continuous ambulatory peritoneal dialysis may be completed in the home without any need to bring the patient into the dialysis center. And the exchanges of the dialysis solution should be performed from 4 to 5 times a day, 7 days a week. Dwell time from 4 to 8 hours. The advantage is not so significant, but it's more consistent, less electrolyte imbalances, frees patient physically and mentally from dialysis center. But what are the disadvantages? More opportunity for infection, must be able to complete exchanges at more frequent intervals, less freedom for work and social engagement outside the home. The best method to treat the chronic renal failure is the kidney transplantation. Nowadays, the average cost of maintaining a successful kidney transplant is just 1/3 of the cost of dialysis. Some problem we have with this lack of donors is the major problem for it. And two main types of human donors exist: living, related or non-related, and cadaveric kidney. So it's the life circuit of the patient having end-stage chronic renal failure dialysis, hemodialysis or peritoneal dialysis, and the best way, the best outcome provides only the kidney transplantation. What about polyclinic follow-up? With chronic renal failure, the success of treatment depends largely on the patient, his motivation and diligence in fulfilling appointments. And the patients need to pay special attention to dietary recommendations, sometimes difficult to implement, and to water salt regimen. And daily self-monitoring of blood pressure and principles of correction of blood pressure is essential. Now I want to say thank you for attention and take care as usual. So goodbye. You may ask some questions whenever you have some questions. I see just a few students who admit our presentation. So I want to say goodbye once more and take care. Thank you very much.